I'm Dr. Robert Jones, and in this lecture we're going to cover sound wave essentials. Sound is a form of mechanical energy that is transmitted by pressure waves in a medium, and it is all around us in a variety of frequencies. Sound carries energy as it travels, and sound exists in the form of physical movement of molecules and particles within a medium. Sound waves only exist in media that contain molecules or particles, and therefore sound cannot travel through a vacuum. Sound will be classified according to its frequency. The unit for frequency is going to be cycles per second, or hertz. So let's now take a look at how sound waves can be classified. Humans can hear sounds in the range of 20 hertz to 20,000 hertz. This is the audible frequency range. Any sound with a frequency below the audible frequency range is termed infrasonic. Anything within the range of 20 hertz to 20,000 hertz is going to be the audible sound range. Anything above the threshold or the upper limit for human hearing, which would be 20,000 hertz or cycles per second, would be defined as ultrasound. Now, diagnostic medical ultrasound are going to include sound waves in the range of 1 megahertz or 1 million cycles per second up to 20 megahertz or 20 million cycles per second. Let's now take a look at some sound wave characteristics. Sound can be characterized by its frequency, its period, its wavelength, or its amplitude. The most important one for you to remember is going to be the frequency, and this is defined as the number of times per second that the disturbance is repeated and is determined by the number of oscillations per second made by the sound source. And as we already talked about, it's measured in hertz. Now let's take a closer look at frequency. Here you have two different sound waves. The top one here is a higher frequency sound wave, the bottom one is a lower frequency sound wave. As you would expect, the higher frequency sound wave is going to have more cycles per second. Now, this is important because clinically, wavelength is an important factor because it is a factor in spatial resolution. A higher frequency sound wave is going to have a shorter wavelength, and it's going to have the ability to discern between objects that are closer together. Therefore, as the person doing the scanning, you always want to use the highest frequency possible. Now, there is a downside to higher frequency sound waves, and that is that they cannot penetrate as far into the tissue. So this is a balance that you have to always keep in mind when you're scanning someone. Use the highest frequency possible that will allow you to penetrate to the depth required. Now here we have two transducers. One is a curvilinear, one is a linear. If you notice here, both have a frequency range. This curvilinear has a frequency range of 5 megahertz to 1 megahertz. This linear transducer has a frequency range from 12 megahertz to 3 megahertz. So you, as the sonologist doing the scanning, have the ability to control what frequency you want when scanning. So always remember that higher frequency means better resolution, but poorer penetration. Before concluding this lecture, let's just briefly look at sound wave theory. So sound waves are going to be coordinated disturbances. The sound waves are going to be longitudinal waves that travel within the tissue, and there's going to be acoustic pressure changes that occur throughout the cycle. There's going to be areas of compression, and there's going to be areas of relaxation or rarefaction that happen. This lecture was just meant to provide a brief overview of sound wave essentials. Next, we're going to move on to what happens when sound gets into tissue. I'm Dr. Robert Jones, and in this lecture we're going to go through ultrasound transmission in human tissue. Now, speed of sound in the human body is going to be determined primarily by the characteristics of the medium, particularly the stiffness, and the density. Now, if you take a look at various tissues within the human body, you can see that with the exception of lung and bone, that the speed of sound is in a relatively tight range from approximately 1460 meters per second to approximately 1600 meters per second. The ultrasound machines work under the assumption that the speed of the sound in the soft tissue is 1540 meters per second. Remember, we talked about how the speed of sound in most soft tissues is within a relatively tight range. Well, they've came up with the number of 1540 meters per second as being the average speed of sound in soft tissues, excluding lung tissue. Now, the machine knows how long a sound beam took from the time it went into a certain point to the time it came back. However, in order to put that in a spot on the screen to create an anatomically correct image, it has to know the depth that it went in, and this is all going to be based on 1540 meters per second. Let's look at acoustic impedance. Reflection of a sound wave occurs whenever the beam encounters an interface formed by two tissues having different acoustic impedance. Now, the greater the difference in the acoustic impedance at that interface, the greater the degree of sound reflection will be. So if you have a sound wave coming in and it hits a soft tissue to liver interface, there's going to be a little bit of a difference here, but still, the vast majority of the sound is going to continue to go on through, and only a small amount is going to come back. Now, if you go to a soft tissue lung interface, or a soft tissue bone or calcified structure interface, there's going to be a much greater difference in the acoustic impedance from one side to the other. So that means that the vast majority of that sound is going to bounce at that interface and come back. Now let's take a look at this image, a sagittal image of a gallbladder here, in order to explain what's going on. So to just orient you real quickly, this is where the transducer is. So this is going to be anterior, posterior. This is head, this is foot. You're going through the soft tissue here into the liver, and then you've got the gallbladder here. So now you've got multiple crystals firing up here. So as the sound wave from each of these crystals enters into the soft tissue, there's going to be a slight difference in the acoustic properties from one side of the interface to the other. So there's going to be, at each of these interfaces, a little bit of sound that comes back, but the vast majority of the sound continues to penetrate in. When you get to this point here, and now you've got a liver bile interface, from this point on, there are no acoustic interfaces occurring, and that's why it appears black on the screen, because nothing is coming back at those time periods. However, when you go in farther here, and now you've got a bile calcified gallstone interface, there's a great degree of difference in the acoustic properties from one side to the other, so the vast majority of the sound is going to come back. Maybe a little bit will go in, but that will continue to keep on coming back, and so basically from this point on, there is no further sound transmission, and that's why this area behind here appears black. And we'll go over in the future lectures, as well as in the artifacts section, on how to clinically interpret this data. It's important to remember that only sound that hits an interface at a perpendicular beam incidence will be transmitted directly back. It's basically angle in is angle out. So it's important that when you're scanning, you want to stay as close to perpendicular as possible to the target organ. Now, it's not possible to remain perpendicular to every structure within the scanning region, but you want to stay as close as possible to 90 degrees to the target interface as possible. This is where you're going to get the best image quality. Now, specular reflectors occur in smooth surfaces at perpendicular angles to the sound beam, while diffuse reflectors occur at interfaces that possess a degree of roughness, and unlike specular reflectors, echoes from diffuse reflectors are not dependent on interface orientation. They're basically scattering. We're all familiar with visual refraction, but sound refraction also occurs. For sound refraction to occur, two conditions must be met. First, the speed of sound must be different on the two sides of the interface. If the speed of sound is the same on both sides of the interface, then you won't have refraction. Secondly, the sound beam must be at an incident on the interface at an angle that is not perpendicular. So here you can see the sound beam coming in at a non-perpendicular angle to the interface. If these two criteria are met, you're going to have some degree of bending of the sound wave. Now, you would think that this could cause major problems. Fortunately, in the vast majority of cases, this presents no clinical dilemma, but we'll go through what potential refraction artifacts can occur in future lectures. But it's something that you want to be aware of. Just want to show here real quick an example of sound refraction. Here you have a short axis view of a blood vessel. Now, as the sound is coming in, you've got a difference in the acoustic properties on both sides of the interface. You're coming at this angle, or this area right here, at a less than perpendicular angle, so you've got bending of the sound wave off of the corner here. And what that leads to is what looks like dog ears here, and because the sound is bending here and not coming back in this line, all the machine can assume is that from this point on nothing is coming back, and therefore it writes that area on the screen as a black area. Now, scattering refers to reflection of a wave in multiple directions, and this provides much of the significant diagnostic information in ultrasound imaging. Attenuation refers to the decrease in the sound beam amplitude that occurs with increasing distance traveled. And you would expect this, that as the sound goes in, it keeps on hitting off of different interfaces within the soft tissue, that it's going to become weaker the farther it goes in. Now, higher frequency sound waves are going to attenuate at a greater rate than lower frequency. So that in part explains why higher frequency sound waves cannot penetrate as far into tissue. Let's just take a minute here and kind of put together what happens with the production of an ultrasound image. Basically what's going to happen is first the machine is going to produce an electrical current. That electrical current is going to come down and it's going to stimulate the crystals in the head of the transducer. They're going to convert the electrical energy into the mechanical energy, and the sound waves are going to be sent into the body. As they hit off the interfaces, they're going to come back to the transducer, where again the mechanical current is going to then be converted back into an electrical current. The machine is going to interpret the data based on how long it took each of the echoes to return. It's going to use the 1540 meter per second of average sound wave speed within human tissue to write each of these echoes at a various depth on the screen. The grayscale portion is going to be based on the strength of that returning echo, and it'll be somewhere from black to white. And this is how we're going to get the formed ultrasound image. You've got upwards of 256 individual crystals here firing, each one obtaining data in a line to create the entire image. From a biosafety standpoint, there's been no independently confirmed or reproducible study that's documented adverse effects on living tissue with diagnostic medical sonography. However, despite this, it's always prudent to scan at the lowest power possible. And there's a principle that they talk about in the ultrasound community, and they call it the ALARA principle. And it stands for as low as reasonably achievable. And we'll go through this in the knobology section, that you want to use only enough power to obtain the desired image. Human tissue lecture. Dr. Robert Jones, and in this lecture we're going to go through and cover instrumentation. Now, the term transducer refers to any device that converts signals or energy from one form to another. An ultrasound transducer, as shown here, converts electrical signals to acoustical energy and vice versa. This is referred to as the piezoelectric effect. Now, an ultrasound transducer has multiple different components. It's going to have a matching layer on the surface. It's going to have multiple PZT crystals, some up to 256 to maybe 300 crystals in the footprint of the transducer. You're going to have wires behind these crystals that are going to be stimulating them with electrical energy. You're going to have a backing material, and this will act much like when you think of a handbell choir that you grab the bell to dampen the sound. The same thing is going to occur here, because these crystals have to both send out information and receive returning information. So you want to be able to dampen the vibration as quick as possible so that it can receive information. And then it's going to be housed in a plastic case. In these ultrasound modules, we're going to be talking about pulsed echo. And that's different than continuous echo. An example of a continuous echo technology would be the handheld Doppler stethoscope that we're all familiar with in the emergency department, to either listen for pulses in an extremity or to listen for fetal heart rate. Now, this is different than what we have with diagnostic medical sonography. With pulsed echo, the crystals all send out information and they all receive information. Therefore, they're able to provide anatomically relevant imaging data. In continuous echo, you have crystals that are solely dedicated to sending out sound waves and those that are dedicated to receiving sound waves. These will be able to provide you with information regarding, let's say, a pulse, but it's not going to be able to tell you specifically where it came from. Now, the electronic transducers are going to have up to several hundred small individual crystals arranged in a variety of configurations. These are going to be referred to as arrays in the transducer head here. Let's take a look at now some of the different types of arrays that are available. This is a linear array transducer, meaning that the crystals are all lined up in a linear fashion. When you hear me talk about footprint, we're talking about the part of the transducer that comes in contact with the patient. The linear array transducers are primarily high-frequency transducers used for superficial imaging, and they will provide a rectangular image as you see here. Now, all of the transducers here are curvilinear arrays. You can see that the crystals are aligned in a curvilinear fashion on all of these transducers here. Now, the curvilinear transducers will have variable frequencies. There's variable footprint sizes. This is a large footprinted. This would be a smaller footprinted. This is a smaller footprinted here. And this is an endocavitary curvilinear array transducer. These are going to produce sector images. Now here you can see the footprints of some of the curvilinear array transducers. This is a larger footprinted curvilinear array. This is a smaller footprinted here, and this is the footprint of the endocavitary curvilinear array transducer. Specifically, here is a large footprinted curvilinear array. This has a frequency range of 1 to 5 megahertz, so these are usually used for general abdominal or obstetrical scanning in adult patients. You can see that here's the footprint here, and you can see that these images will be, that these transducers will produce a sector image. Here's an example of a small footprint curvilinear array. This one also has a range in the 2 to 5 megahertz range, so it's primarily used for general abdominal, cardiac, and obstetrical scanning. It's got the smaller footprint that you can see here, and so this is also going to produce a sector image, but it's going to be a wider image going from the smaller footprint and then fanning out. This is a cardiac image here. This is an example of an endocavitary curvilinear array transducer. You can see that this also produces a sector image. You've got the small footprint here, and you can see that this is a very wide sector image here, and this is being used here to evaluate the female pelvis. It can also be used for peritonsillar abscess scanning, and we'll talk about that in future modules. This is an example here of a phased array transducer. These contain elements in the transducer head that are pulsed as a complete group with a slight timing delay or phasing. So you can see that there is a very narrow apex here, but this produces a very wide sector image here. These transducers are primarily used for cardiac scanning, and these have frequency ranges for adults usually within the 1 to 5 megahertz range. This concludes the instrumentation lecture. I'm Dr. Robert Jones, and in this lecture we're going to go through knobology. Now, the keyboard of the ultrasound machine can appear intimidating, but we want to go and show you how to demystify this, because it's going to be essential that you know how to control these knobs in order to produce the highest quality image possible. Let's first look at the power output. This will control the strength or intensity of the sound wave. It's going to be expressed in units of decibels, and an increase or decrease of the intensity by 3 decibels will therefore multiply or divide the intensity by 2 respectively. Remember, increasing the power increases the acoustical exposure to the patient. So here you want to follow the Alera principle and use only as much power as needed to obtain the desired image. Here's a split screen image showing a an image on the left where the power is set very low, and here's the image where the power is set correctly. This was done on a phantom, and you can see here are 3 small anechoic structures, each one becoming progressively smaller. You can see all 3 of them here clearly in the surrounding soft tissue. There is no artifactual fill-in here. If you take a look at this image on the left, you can barely see the largest anechoic structure, but the other ones are difficult to see, and that's because the power is too low. You want to make sure that you have the power set correctly so that you don't miss any key sonographic structures. Let's now look at gain. Gain refers to the degree of amplification of the returning sound. Increasing the gain does not increase acoustical exposure to the patient. Using a known anechoic structure to assist in correctly setting the gain is going to be important. You want to try and increase the gain before you increase the power. Here's another split screen image obtained on a phantom. You can see that this image on the left here has an appropriate amount of gain. By increasing the gain, you're going to increase the amount of sound that's placed on the screen. And here you can see that while you can still see the anechoic structure, these other echogenic structures here are difficult or even impossible to see. So some sound can be good, too much sound coming back can be bad. So you want to make sure that when you set this, you base it on anechoic structures. You'll turn the gain up until you see artifactual fill-in, and then you turn it back. At that point, you'll know that you have an adequate gain setting. Here's an example here of decreasing the gain. You can see that as the gain is decreased, you lose the grayscale appearance in areas. So you want to make sure, like I said, that this gain setting is correct, and this is something you're going to work on with every image that you obtain. Here's an example here of having the gain too high. You can see that there's too much additional noise here that basically blurs out all the key structures that you're looking to visualize at baseline. Now the time gain compensation will compensate for the loss of energy in the reflected signal due to attenuation. Remember, no matter what tissue you go through, that sound wave is going to be weakened as it goes in. But you want to make sure that when you're imaging a solid organ such as a liver, that the liver has the same appearance in the near field as in the far field, and this can be obtained through the time gain compensation. Now this is either going to be controlled through a 3-knob control system, which is not uncommon on some of the handheld machines, or more traditionally through the use of slide pods, where each one of these will control the gain at a particular depth on the ultrasound image. Here's an example here of where you're decreasing the time gain compensation in the near field. As the image starts off, you can see that there is the medium level echoes, but now as we decrease the gain in the near field, you can see that it becomes basically black. And so basically what we've done here is taken the slide pods from this nice even curve and moved the ones in the near field over to the left, thereby decreasing the amount of echo return in the near field. Here's an example of decreasing the time gain compensation in the far field. So by doing that, you're basically going to take the echoes in the far field and selectively reduce them. And so what we end up seeing here is that by moving these slide pods to the left, the image becomes darker selectively in the far field. Now there may be times that you want to do this. If the sound is passing through an anechoic structure such as a urinary bladder, it's not going to be weakened, and the areas in the far field may appear particularly bright, and therefore you may need to decrease those selectively. But here you can see that this is excessive decrease in the far field here, and you're taking away the ability to discern key structures within the far field. Let's look now at focal zones. Only electronic transducers will have variable focal zones, and the focal zones will usually be identified on most machines as an arrow on the edge of the screen, and we'll show that in a second. The focal zone should be set at the level of the desired structure. It's also important to remember that while the focal zones are an important thing to consider, you don't want to use multiple focal zones. You don't want to use multiple focal zones when scanning moving structures, since this is going to decrease the overall frame rate and it'll produce a choppy image. So on a cardiac scan, you would want to avoid using multiple focal zones. Here's an example here on a Phantom. We've got a split screen here where the focal zone is in this mid-range here, and then we brought the focal zone down in the far field. You can see that the structures in the far field are better visualized when the focal zone is brought down to about that level. So it's important to keep that in mind when scanning, that you keep the focal zone at the level of the target structure. Here's an image here obtained on a Phantom where you can see the effect of moving the focal zone up and down. You can see how that affects image resolution at the different levels. The resolution is going to be best when the target structure is aligned with the focal zone. Overall, remember, the depth is going to be limited by the frequency of the transducer, but you have the ability to increase or decrease the field of depth within that range depending on the view you desire. It's important to keep in mind that the structure of interest should ideally be centered in the middle of the screen. Frequently I'll see people scanning superficial structures, and they'll have an excessive amount of field of view, and they're having to squint to try and see what they're looking for, and it's crammed into the near field. So make sure that you have the image appropriately set, or the target organ appropriately centered. Now you have the ability to use the zoom function when scanning. Right zoom is going to be a true magnification of the desired area, since the pixels are going to be reallocated and not just enlarged, whereas read zoom is not a true magnification, since the memory pixels themselves are enlarged. Most machines now use right zoom technology. However, when you have a frozen image that you hit the zoom button on, it's not uncommon that read zoom technology is used, so you're best to zoom an image while you're scanning real time. Let's take a look at frequency. Remember, transducers are multi-frequency. The higher frequencies will provide better resolution but less penetration. So you want to set the frequency to the highest possible frequency that will allow penetration to the target structures. Here's a split screen image obtained on a Phantom. Here you've got the frequency set to the lowest possible. Here you've got the frequency set to the highest possible. So if we were attempting to scan a deeper structure, you can see how important it is to lower the frequency. That when looking at the deeper structures here, they're not as clearly visualized when the frequency is set too high, but you can see that the deeper structures are better visualized when the frequency is appropriately lowered. So this is something you have to control, and this is something you're going to need to change based on the depth of the target structure. But remember, overall, higher frequencies for superficial structures and lower frequency for deeper structures. Here's another split screen image obtained on a Phantom. Lower frequency here, higher frequency here. You can note that with the higher frequency that you can see the discrete echoes better with the higher frequency as opposed to the lower frequency. You can see that the individual echoes appear better defined with the higher frequency as opposed to the lower frequency ones on the left here. And you can see that here also, looking at these smaller echogenic foci right here, they're clearer on the higher frequency as opposed to the lower frequency. Concentrate on this area right here. Notice that when the frequency is highest, you can see the individual echoes, but as the frequency is lowered, they all tend to blur together. So here's higher frequency, and here's the lowest frequency. So when you're looking at a very large structure, let's say you're looking at a 8 centimeter abdominal aortic aneurysm, it's probably not going to matter as much. But if you're looking for a several millimeter embryo, then having the the frequency set at its highest possible is important, because you can see that there is a difference between the highest frequency and the lowest frequency range. Let's look at tissue harmonics now. In conventional imaging, frequency of transmitted and returning sound waves are the same. However, harmonic frequencies are produced as a sound wave travels through the tissues, and these are higher frequency multiples. Therefore, the use of tissue harmonics, if you have it on your machine, may improve image quality, particularly in obese patients. Here's a split screen image on a phantom. The image on the left is obtained without harmonics. The image on the right is obtained with harmonics. Notice in the deeper anechoic areas here, you can see that the wall is better defined using the harmonics as opposed to not using the harmonics. So you'll see on a lot of the images throughout these modules that tissue harmonics is used, and I think that it does help with a lot of image quality. But this is something that you may have to play with on each individual scan. There may be times where you put harmonics on, don't like how it makes the image appear, then it's fine to just go back to the non-harmonics images. Compound imaging is becoming more readily available on machines, and it combines images from multiple lines of sight to create a single image. It improves image quality due to reduction of speckle, clutter, and other acoustic artifacts. And compound imaging may minimize shadowing and posterior enhancement. So this may be good or it may be bad, and we'll talk about this in future modules as we go through different applications. Now here's an image using the same frequency settings, courtesy of Sonosite, where the echogenic structure within the liver is much better visualized when compound imaging is utilized. So this is something that you want to play around with when you're scanning to see how this affects the quality of each of the images that you're obtaining. You're going to use the M mode function frequently during your scans, and M mode stands for motion mode, and it's a one-dimensional motion display of the two-dimensional image, and it can be used to confirm the presence or absence of motion on a static image. It can also be used to obtain measurements, but predominantly you're going to use this to determine the presence or absence of motion. Here's an example of a subcostal view of the heart in a patient who is in cardiac arrest with asystole. Now when you look at the video clip here, you can see that there's no cardiac activity noted, but how can you prove that on a printed image? And you can use M mode to do this to confirm the absence of any movement. Here's an M mode in a first trimester pregnancy scan. You can see that the gate is dropped through the embryo here, and it was dropped through where the embryonic heart is. And you can see here on the one-dimensional M mode clip that there is confirmed cardiac activity here, and you're actually able to then calculate out what the heart rate is. But this proves that this embryo at this time did have cardiac activity. Now here's an M mode image. It was a sagittal image of the inferior vena cava, and here is the inferior vena cava here. And you can see that when the patient sniffed, that the diameter of the inferior vena cava decreased, and we were able to use this M mode image in order to obtain the different measurements with and without sniffing. So this is another application for M mode. Now this concludes the knobology video. I'm Dr. Robert Jones, and in this lecture we're going to go through grayscale image optimization. Let's take a look at the first step. It's transducer selection. You need to match the transducer to the clinical application. The depth of the target structure and the size of your surface window are going to be the major factors in transducer selection. You want to select the highest frequency transducer that will allow you to image the target structure. For superficial structures, you're going to want to use high frequency transducers, usually in the 5 to 10 plus megahertz range, and all of these are high frequency transducers. This is a 5 to 8 megahertz, this is a 3 to 12 megahertz linear transducer, and this is a 7 to 15 megahertz hockey stick linear transducer. Here's an example of superficial structures scanned with a phased array and a linear transducer. You can see here that each of the individual echogenic areas are best seen in the near field with the linear transducer as opposed to the lower frequency phased array transducer here. So again, superficial structures are going to be best imaged with the high frequency transducer. In this case, it was a linear transducer. For deeper structures, you're going to use transducers in the 2 to 5 megahertz range, and all of these transducers would be adequate for deeper structures. This is a phased array transducer here in the 1 to 5 megahertz range. This is a small footprinted curvilinear in the 2 to 5 megahertz range, and this is a large footprinted curvilinear in the 1 to 5 megahertz range. And here's an example here of a sector image using a curvilinear transducer that's able to scan deeper into the peritoneal cavity. Once you have selected the correct transducer, make sure that you've got your preset selected appropriately. Here's an example here of a abdominal scan. You've got a sagittal view through the liver here. You've got anterior to posterior head and foot. You've got liver here. You've got kidney here. With the machine set to the abdominal preset, you're able to obtain this image right from the start. However, here we are in a superficial preset, and notice that we're only scanning several centimeters down into the soft tissue. It's going to take a lot of work in terms of changing the knobs to go from here to here. So make sure you've got the correct preset done. This will take away probably 90% of the work you need to do in terms of controlling the knobs. Next, you're going to want to go ahead and scan through your target area. This is a patient that we were going to scan the gallbladder. So you can see here's the gallbladder in a sagittal plane here, and we've basically gone through the liver and swept over until we found our target structure. Next, you're going to want to adjust the overall gain. And you can see here we're using the liver as the window. We turn the gain up until we get artifactual fill-in within the vessels, and then we lower it. Now we know we have our overall gain maximized. It was too dark when we started, too bright at this point, and now we bring it back to here where the overall gain is optimized. Next, you're going to want to adjust the time gain compensation if necessary. You're going to want to make sure that here the liver in the near field looks like liver in the far field, and you would do this by adjusting the time gain compensation. Next, you can fine-tune your depth. Make sure that the target organ is in the center of the screen. This will allow you some visualization posteriorly here as well as anteriorly for any adjacent pathology. Next, you can adjust your focal zones. Make sure that the focal zone is at the level of the target structure. And here you can see we bring the focal zone up to the level of the gallbladder in order to maximize image quality. When scanning non-moving structures, you can also add multiple focal zones, especially when you're trying to look at very small structures. When scanning an 8 centimeter abdominal aortic aneurysm, you do not need multiple focal zones. However, if you're scanning a very small superficial structure or a very small embryo within the first trimester, then having more than one focal zone may be helpful. But at a minimum, you want to make sure that the single focal zone is at the level of your target structure. Next, you can decide whether or not tissue harmonics and/or compound imaging will benefit you on your current scan. Here we've got the gallbladder, you've got the tissue harmonics on, and you can see that you've got nice delineation of the liver to the gallbladder wall to the gallbladder lumen here. And you can see that we remove the harmonics here. You can see that the borders are not as clean as they were before. And you can see that even when we change the frequency from lower to higher, that harmonics provided us with a more clean image with better resolution. So that's what we went ahead and continued to scan with, was the tissue harmonics mode.